Hello, and welcome to One-on-One Ultrasound in Emergency Medicine. My name is Dr. Fahad, and I'm a consultant in emergency medicine. In today's video, I want to cover the basics of echocardiography for the emergency physicians. The aim is simple: to help you understand the core echo windows we use at the bedside and how to recognize them quickly and confidently in a real clinical situation. What we are not trying to do is to replace formal cardiology echo. This is focused point of care ultrasound. The goal is to assess cardiac structure and function rapidly, especially in the unstable patient. Today, I will go through with you 5 essential views: parasternal long axis view, parasternal short axis view, apical four chamber view, subcostal view, and the last view is for inferior vena cava. Let's start with parasternal long axis view. To obtain this view, place the probe just to the left of the sternum, usually in the fourth intercostal space, with the probe marker pointing towards the patient's right shoulder. This view gives you a longitudinal slice through the heart. You should be able to identify the left ventricle, left atrium, mitral valve, aortic valve, interventricular septum, and the posterior wall of the left ventricle. In emergency practice, parasternal long axis view is extremely useful. It allows you to assess left ventricular size and contractility, look for gross valvular abnormalities, and identify pericardial effusion. It also helps you judge whether the left ventricle is dilated or underfilled, which is crucial in shock states. Next is the parasternal short axis view. From the parasternal long axis view position, rotate the probe 90 degrees so the marker points towards the patient's left shoulder. You are now cutting the heart in cross section. Depending on the level, you can assess the heart at the level of the papillary muscles, mitral valve, or aortic valve. This view is through the mid-papillary level, and you can see the right ventricular cavity, the left ventricular cavity, interventricular septum, and the papillary muscles. The parasternal short axis view is crucial in echocardiography because it offers a cross-sectional look at all the four cardiac valves. It assesses the left ventricular function, wall motion, and any thickening of the ventricular wall. It also helps you identify any congenital defects like VSDs, and it also evaluates right ventricular function. The third view is the apical four-chamber view. Place the probe at the cardiac apex, usually near the point of maximal impulse, with the marker directed towards the patient's left side. You can rotate the probe left or right or up and down to get the most optimal view, and sometimes it may be necessary to ask the patient to lie on their left side. This view shows all the four chambers of the heart at once, both atria and both ventricles. It is one of the best views for comparing right and left ventricular size and function. In emergency medicine, the apical four-chamber view is particularly useful for identifying the right ventricular dilatation, which raises concern for pulmonary embolism, and for assessing overall cardiac function. It also allows a good visual assessment of mitral and tricuspid valve movement. Now, to recap, we have spoken about parasternal long axis view. Second view was parasternal short axis view, and the third view was apical four-chamber view. Now let's talk about parasternal short axis view a little bit more. There are 3 different levels at which you can obtain parasternal short axis view, which is at the mid-papillary level, at the mitral valve level, and at the aortic valve level. Parasternal short axis view at the mid-papillary level is the most common view that we would like to get in an emergency setting. It can give you very useful information regarding overall ejection fraction, right ventricular dysfunction, and left ventricular regional wall motion abnormality. Second type of parasternal short axis view is at the mitral level, where you will obtain a fish mouth view. To get the mitral valve level, from the mid-papillary level, slide the transducer towards the sternum, towards the mitral valve, which is the base of the heart. The anterior and posterior leaflets of the mitral valve should come into the view. Third type of parasternal short axis view is at the aortic valve level, and it's also called the Mercedes-Benz view. And you can use this view to visualize the right ventricle, the right atrium, left atrium, aortic valve itself, tricuspid valve, and the pulmonic valve. To achieve this view, tilt the tail of the probe inferiorly and point it towards the aortic valve. As you do so, the aortic valve should come into the view with its leaflets representing the Mercedes-Benz sign. One of the other views while doing the 4-chamber view is apical 5-chamber view. Now, of course, there are not really 5 chambers in the heart, but in echo, the 5th chamber is when you see the appearance of the aortic valve and the left ventricle outflow tract. This view can be useful to calculate the cardiac output of the left heart. So after the parasternal long axis view, short axis view, and apical 4-chamber view, the 4th view is the subcostal view. The probe position for this view would be subcostal area with the probe direction towards the patient's left shoulder and the pointer directing towards the patient's right. This view will again give you right ventricle, left ventricle view, left atrium, right atrium, the mitral valve, the tricuspid valve, and the interventricular septum. Now, this view is particularly important during resuscitation, as during CPR, the only possible position available for focus is the subcostal area. This position will give you the same view as the apical 4-chamber view and helps you guide further resuscitation. The last part of the echo in emergency department is to obtain the inferior vena cava view. This view is particularly important to estimate the central venous pressure and the fluid tolerance. Place the probe in the subcostal area in the middle and identify the aorta. Once you have identified the aorta, then slide the probe towards the patient's right till you identify the inferior vena cava. By moving the probe up and down, you would be able to evaluate the inferior vena cava and also see the IVC going into the right atrium, and sometimes you can also see the hepatic vein. Once you have obtained the IVC view, you will need to assess for IVC collapsibility. For spontaneously breathing patients, have them take a deep breath or have them sniff in. The maximum IVC diameter will be seen during expiration, and the minimum IVC diameter will be seen during inspiration of these patients. For ventilated patients, the effect will be opposite. The maximum IVC diameter will be seen during inspiration, and the minimum will be seen during the expiration. According to different studies, you can correlate between the IVC size and collapsibility and the pressure in CVP. For example, if the IVC size is less than 1.5 centimeter and the collapsibility is more than 50%, you possibly have a pressure of 0 to 5 millimeter of mercury, which is considered as a low central venous pressure. If your IVC size is 1.5 to 2.5 centimeter and there is more than 50% collapsibility, then you have possibly a pressure of 6 to 10 millimeter of mercury. Similarly, if you have less than 50% collapsibility with a size of 1.5 to 2.5 centimeter of inferior vena cava, then you have possibly a pressure of 11 to 15 millimeter mercury. Now, if the IVC size is more than 2.5 centimeter with less than 50% of collapsibility, then you have a higher pressure of CVP, around 16 to 20 millimeters of mercury. Okay, now let's go through how to measure actually the diameter of the IVC, and then based on the measurements, how we are going to calculate the IVC collapsibility index. You're going to take a 2 centimeter distance from where the IVC is entering into the right atrium. Then measure the maximum diameter of the inferior vena cava, which will be in expiration, followed by the minimum diameter of the inferior vena cava, which will be in inspiration. Always remember that this is for the spontaneously breathing patients. Now, to calculate the IVC collapsibility index, you have a formula which has IVC maximum diameter minus IVC minimum diameter, then divide that by IVC maximum diameter multiplied by 100, and you can see the example below. This is an example of a completely collapsible IVC showing that the patient is completely underfilled, whereas in contrast, you can see a completely distendable IVC without any collapsibility showing the overfilled status. So in the end, just to recap, the focused echocardiography is a core skill in emergency medicine. Parasternal long axis, short axis, and apical 4-chamber views form the foundation. The IVC assessment supports the volume assessment but must be interpreted clinically, and the regular practice builds confidence and pattern recognition. Thank you very much for listening, and stay tuned for the next video.